offer by using discount code CHICAGO.
It's open enrollment season, and MediShare is a Christian healthcare sharing ministry that saves most families about $500 a month. Google MediShare and see if it is a fit for you.
7:37 Team Hochberg Traffic Center time, and Jim Talamonte.
In Oak Brook Terrace this morning, getting word of a major collision on 83 southbound at Hodges Road. Expect restrictions and a possible closure in that area. That's southbound on 83. There's also a collision in Carroll Stream on Lies Road west of Gary. There has been an uptick in the number of high-speed collisions and crashes with injuries, so law enforcement officers are stepping up enforcement of posted speed limits. On the Kennedy Expressway, starting tonight at 9 o'clock, road construction will cause a lane shift on the inbound Kennedy around Canfield. Again, that starts tonight. That lane shift will be to the right between Canfield and Harlem for long-term work. That's traffic. I'm Jim Talamonte on AM 560 The Answer.
Chicago's Morning Answer continues next. In our 1-hour heating and air conditioning weather center, windy and sunshine this morning, leading to clouds, rain showers, maybe a flake or two of snow in the afternoon, and a high of 48. 39 right now. Next news at 8, breaking news as it happens. Chicago's Morning Answer with Dan and Amy continues next on AM 560, The Answer.
Listen to AM 560, The Answer, online at 560theanswer.com, on the AM 560 mobile app, and your Alexa-powered smart speaker, on TuneIn, iHeart, and radio.com. When you've got questions, he always has an answer. It's Sean Hannity, this afternoon at 2 on AM 560, The Answer.
Top of the morning, Dan and Amy, and a happy and holy Thursday and Passover to our friends, some of whom are listening, some of whom are abiding their religious traditions. Difficult time. It's, in a way, this is a refuge for people, I think, certainly for the faithful. Numbers just out, like Scott mentioned, 6.6 million filers for unemployment this week, another 6.6 million. So that's 17 million in 3 weeks. Lives versus lives, an economy versus not an economy. The prospect of a higher standard of living versus the prospect of a lower standard of living. You cannot bail yourself out of these choices through redistribution of other people's money or printing money. That's a fact. That's something we actually do know. And those are the conversations that should be happening, at least in part, when the public health experts aren't speaking, but the policymakers and the decision makers are at those task force briefings and generally speaking. It's adult time. And while the press is so focused on what did Trump know and when did he know it?
I know. So sick of that argument.
What did Tony Fauci know and when did he know it? Oh, and by the way, this is not a criticism of Tony Fauci, who I think has generally been humble and restrained and talks about what he knows and is honest about what he doesn't know. And that's that's the more interesting question to me. That's what we should be talking about as well on the public health side, it seems to me, which is what did no one know, if you want to go back and play that game and then just end that game and then focus on what do we still not know that we need to make decisions prospectively. Just to underscore my point, on January 23rd, AMA podcast, Fauci downplayed the virus's potential impact on the U.S., noting all 5 cases were travelers from China. Asked whether the U.S. might contemplate citywide shutdowns like those China was enacting at the time, there's no chance in the world we could do that to Chicago or New York or San Francisco, but they're doing it, so let's see what happens. On a day later, the former head of the WHO's response to SARS, Dr. David Hyman, said the coronavirus looks like it doesn't transmit through the air very easily and probably transmits through close contact. CDC press release January 24th. The immediate risk of this new virus to the American public is believed to be low. And again, the administration, January 31st, Fauci, we still have a low risk to the American public, echoed by HHS Secretary Azar. I want to stress the risk of infection for Americans remains low. Well, to some extent, they're not wrong. as this is playing out, you have 432,000 cases. That's barely more than 0.1% of the American population. And obviously, I understand the social distancing and the other evasive actions that were taken, guidelines recommended, has a material impact on that number. And when Fauci said earlier that this is not, or earlier in the month of January, that this is not as dangerous as the seasonal flu in terms of lethality, he may end up being right. And again, it's based on what we knew at the time and then the measures that were taken since that time. So the cheap, the most frustrating, one of the most frustrating things about this is the unwillingness of policy leaders to confront adult questions. And the other is the cheap shotting. I think Tony Fauci is a honest actor in all of this, but so are a lot of the politicians who are otherwise subjected to obscene questions when they're by the DC press corps when they're not asking about pardoning the Tiger King, for goodness sakes. For more on this, we're pleased to be joined by Dr. Ann Schuchat. She is the principal deputy director, of the CDC. Dr. Schuchat, thanks for joining us. Appreciate it.
My pleasure to be here.
So when it comes to where we're at now, what we know and what we don't know, and what we need to know before we can make informed decisions about reopening. One of the things that both Drs. Birx and Fauci have mentioned is this antibody testing. 25, the CDC guesstimates, and Fauci is, again, we have no idea. If I had to guess, 25 to 50% of the population is asymptomatic. How can we get an answer to what we don't know there? Because that seems to be something that's emphasized by medical professionals as something we need to know to have confidence in a phased-in reopening.
Let me describe three key things that need to be in place for reopening of different components of communities. The first is the healthcare system. We need to have enough intensive care unit beds, enough ventilators, and enough healthcare workers to be able to treat an increase in cases. If we reopen and things get worse rapidly, we need to have the hospitals ready for that. A second thing is the public health capacity. We need to make sure that your local or state health department can keep up with the cases that do occur and be able to quickly isolate them, trace their contacts, and keep their contacts from spreading to others. And thirdly, we need to make sure that things are truly getting better, that the epidemiologic indicators are looking better and better, declines in new cases, declines in deaths and so forth in the context of good availability of testing. That said, we want to get our critical workers back. We want to get people back. We want the economy to recover, but we don't want to open so quickly that things get very rapidly worse and we have a much bigger next wave. The antibody test is a component, but it is not the whole answer. I don't think that most Americans are immune to this virus yet. I do think that the social distancing has been phenomenally effective at slowing the increase, but we're still seeing large numbers of new cases every day. And tragically, as you know, in Chicago, we're seeing it hit certain communities harder than others. We have to get ahead of this in terms of the healthcare system being able to treat people and the public health system being able to help prevent.
But just on that point about the healthcare system being able to treat people and handle a potential increase, I get that. But if you're trying to game plan resources, and will you have the resources to meet the potential need, it seems to me there's a cart before the horse. Don't you want to have a better idea of what the vulnerable population is, the population that's not immune is, so that you can model the resources you'll need prospectively?
Yes, the most we do know vulnerability right now, that the older you are, the more vulnerable you are. People with underlying diseases like diabetes and heart disease are more vulnerable than others, but even healthy young people can get quite sick from this, and everybody can spread it. Based on the latest information we have, we don't think the majority of Americans are immune to this. It may be that more healthcare workers have already been exposed, and that's a real priority for us to understand. We're developing, and many groups are working on antibody assays and trying to understand how they will predict and what they can tell us. But I think that even the best information we have today suggests that most people haven't yet been exposed to this virus and are not yet immune. So we, of course, would love to have a vaccine. We'd love to have treatments, and hopefully we'll get treatments in the next few months. But we can't count on every single person having an antibody test and that being a solution. One thing to say about other coronaviruses is that the antibodies may not be long-lasting. So even if we knew that you had antibodies, we don't know that you're going to be protected a few months from now. Well, this is a totally new virus, and we need to understand the immune protection better.
Right. There was a story out yesterday about 51 individuals in South Korea who were had the virus, were cleared, testing positive again, to your point. So that is a legitimate concern, no question. But going back to the entire population, two things. One is you could do representative testing that you could model based off of.
Absolutely,
right?
And that's what we're doing right now. Absolutely. We've got collaborations with Washington State and New York State. We're getting the samples and running them, trying to understand in those places that were hit earlier than other places, what is the level of immunity. A number of states are developing that ability as well. And I think you point to a very good issue that we can learn a lot right now about what's already happened in our communities. The early results we have are still small, so I can't make generalizations, but that's a big priority. We're scaling up to be able to do many thousands a day, and there's labs in Washington State, New York State setting up the same way. We have some work to develop partnerships with commercial labs to be able to do high throughput antibody testing. So I think you're pointing at a good area of need for emerging data. That isn't going to answer the question about what happens next week or the week after, but it'll give us very good information for planning over the next several months.
Well, say in a city like Chicago, Governor Pritzker is upset today or yesterday because he wants to be testing 10,000 a day and we're only testing 6,000 a day. When could we get up to that 10,000 a day?
Yeah, the laboratory testing has been so frustrating for everyone. It turns out that different tests need different materials and swabs, and as a nation, while we've really ramped up the variety of tests and the components needed to get that testing done, we're not where we need to be. So I am so sorry for what's going on in Illinois and the challenges. The National Response Coordination Center, the NERC run out of Washington with FEMA and Health and Human Services and CDC up there, are really working on that global supply of the lab components to better supply both the hard-hit areas like Illinois and then the rest of the country. So we need to get the numbers up, and we need to have the results very quickly available. There's good news that there's some new tests that can give results rather quickly. They don't do the high throughput testing yet, but we're seeing increased in availability of tests. We know that on the individual level. I know it's frustrating. We have some priorities of who needs to get the tests as a priority. People in the hospital who are quite ill, we need to get those tests done right away so that we can get the answer and make sure that the individuals who could spread are not spreading and that the healthcare workers can take precautions. We need to get sick healthcare workers tested quickly so that they can get back to work.
Why are they doing so many post-mortem COVID testing? Like I had a friend who recently passed away from cancer, and then they did a COVID test on him. I thought that was strange.
Yeah,
so his cause of death was COVID-19 and not cancer, but he was dying from cancer.
Yeah. Well, I don't know the extent of that's going on around the country. What I can say is there's a problem often with what we call nosocomial spread, where you're in the hospital for one thing, but then you get something else that's from the hospital. We actually need to know whether individuals who are in the hospital for surgery or for cancer treatment are infected by healthcare workers or other patients, because that's a warning that we have to clean up our act in terms of preventing infection spread in hospitals. We saw in nursing homes around the country that this can spread very rapidly. So it may be that some of the postmortem testing is to better understand, did this person get COVID in the course of their illness, and is there something we need to follow up on in terms of prevention? But I agree that it's kind of too late for that person, but it may be helpful in terms of preventing other infections.
I want to go back to some of the projections that continue to be revised down. The IHME study in particular projected deaths, as Dr. Birx addressed last night, and now in the neighborhood of 60,000, down from 102 to 240,000, which is down from other studies in the hundreds of thousands or millions, in addition to how off the IHME study was in terms of the incidence of hospitalizations, so thinking about resources again. Now I understand what Dr. Burke is saying. I mean, part of the reason it's down, and everybody's happy about that, is because of the evasive actions that have been taken and because of Americans' compliance with the guidelines and with shelter-in-place orders and all that. I get that. But are we in a bit of a trick bag here where we say we have to continue to do this because we're saving lives and it has the potential, and maybe there are early indications that it's starting to bend the curve in the direction we want it bent. But then we can't reopen our economy. We can't get people back to work because there's a prospect that it could spike and then we're going to be right back in the same place. And we're not exactly sure what kind of resources we would need to make sure we can accommodate a spike. And so it seems to me we're sort of like being pulled in multiple directions at the same time.
The models don't tell us everything that we want to know. We've learned a lot about the virus. It's easily spread. It can be severe. It can, the doubling time in the community can be, 2 days or so. You can really ramp up an exponential increase. But we don't know exactly what's going to happen with or without intervention in any given community in the U.S., let alone around the world. We have to take this seriously. We need to use the models to help us understand which interventions are the most impactful and what kind of resources we have to build towards. Because as everyone in America has seen, you can't get masks, you can't get ventilators overnight. It takes time to produce them. So I agree with you that the prediction aspect of models is extremely frustrating. We try to use them for direction and for impact of different interventions rather than for numbers. The earliest models on this scenario that we're seeing had millions of deaths in America with no intervention at all. So we were very concerned right from the beginning in January at the CDC because what was happening in China that we could see, let alone what we couldn't see, was very concerning.
What about this? I mean, this is sort of a layman's suggestion that you've just being bandied about. I'm sure you've heard it, but the idea that the reopening when it occurs, community by community, not state by state necessarily, and you see other countries moving to reopen their societies: Austria, Germany, Norway, Denmark, in addition to what Sweden has been doing generally, and guidelines in place for the reopening, like masks and social distancing and other such things that we're doing as well, but. The idea that you do a gradual reopening community by community, and you also sort of continue to have a shelter-in-place guideline, if not order, at the state and local level for vulnerable populations, meaning older people or people with underlying conditions.
Yeah, absolutely. I have to say that when we were first following this virus, we thought we could do what was needed by the shelter in place for the vulnerable. The strategy that Singapore used was to protect the vulnerable. They didn't have to shut things down.
Right.
But they didn't lose control of the contact tracing and cluster detection. They didn't get the widespread community problem that we have. We probably had so many importations from Europe that we just couldn't keep up with it in terms of the month of February and March. But I think that issue of really protecting the vulnerable is a critical one. And so that's a component of how we might reopen. We know, though, that we were seeing that exponential growth until we got, millennials to stay home as well. As you say, there may be that as we get more information about how much infection there's already been in some of the younger populations, the issue is to protect the older populations. We had to keep the younger populations from spreading. But, for instance, we might be able to open schools earlier than other places because we don't have as much information about school-aged children being a major driver of spread. We think adults running around with a lot of social contacts may have been more important in spread than children. And that's different from influenza. With influenza, it's like kids and school-aged kids are the big spreaders of that virus.
She is Dr. Ann Schuchat. She is the Principal Deputy Director of the CDC. Dr. Schuchat, thanks so much for joining us. Very helpful. Really appreciate it.
My pleasure.
And she joined us on our turnkey.pro answer line.
If you're talking about it, Dan and Amy are talking about it. It's Chicago's Morning Answer on AM 560. The Answer.
A business needs to be built on a great foundation, one with the framework of integrity and tradition. Chapel Design Build delivers just that. providing design, build, and general contracting services using Butler Steel Building Systems. Their projects dot the landscape from O'Hare to DeKalb. You see their work in office and warehouse additions, recreational facilities, large-scale distribution centers, and manufacturing plants all over northern Illinois. Partnering with Butler Steel Buildings, Chapel Design Build has developed an extensive subcontractor base and valuable market knowledge to get your quality-built project completed on time and on budget, ensuring your project is a success for your business and one that you will be proud of for years to come. The goal is to build lasting relationships with their clients using buildings that last from Butler. Get started on your next building project built with Butler Steel. Visit chapeldb.com. That's Chapel D as in design, B as in build,